Once we know about the optics and we are comfortable with knowing the different parts, we'll go on to the technique of doing indirect ophthalmoscopy. So as Dr. Vishal very nicely pointed out, you have two parts to this instrument. You have the knobs, the headgear, and you have the illuminating system which is in this box. Now going on to the first part, that is correct positioning and adjustment of the bio headset. Many times postgraduates are in a rush to just wear this instrument and start doing the indirect. This part is very important because you have to spend some time with the patient, at least about 20 minutes to 25 minutes doing the entire fundus examination and drawing. So if this instrument is not snugly fitting onto your head, it will be difficult because you will be in a hurry to take it off. So these two knobs should be nicely, snugly fitted from the top and the back, but not too tight so it is not uncomfortable for you. So this is how you do it. Now the rheostat, this is very important. The intensity should not be too bright because if it is too bright, there will be immediate blinking, patient will be uncomfortable, you will be uncomfortable. So it should always be to the medium, okay? Enough so that you can see all the structures, but not enough to dazzle the patient. So this is the rheostat on the side, which you can increase or decrease the light. So this is what it is. Here it is on this top knob over here. Now the lever can be moved to converge the illumination and the viewing beam so that a stereopsis can be achieved in small pupils, that is 2 mm pupils. Okay, so there is a lever over here. Now comes the adjustment knob. Adjustment knob is very important because you have to adjust the height and the angulation of the optics. This is the adjustment knob in which you adjust the height and the angulation. Okay. And then adjustment of the interpupillary diameter. Just like you do surgical cases on the operating microscope in the OR, just like when you wear this instrument, you have these two knobs over here in which you adjust the interpupillary diameter. So you can see that this is the interpupillary diameter. You have to adjust it according to your IPD. Now the filters are very important. It also comes as, sometimes it comes as short notes in your exam. What are the different filters that you use? So you have the red free filter. This is the filter knob over here. You have the red free filter which blocks the structures below the RP and hence enhances the contrast of the retinal vessels and the hemorrhages. It helps in the cup disc ratio assessment and it helps to identify the nerve fiber layer dropout, which is a sign of glaucoma. The blue filter can enhance reflectivity of the optic distrusion and it is for use for fluorescein angiography. And the yellow filter reduces the UV exposure. So spot size, as Dr. Vishal had mentioned, there are different spot size over here which you can use to, if suppose it's a very small pupil, then you reduce the spot size. Now, once you're comfortable with wearing the instrument on your head, you have to be comfortable with the surroundings. So firstly, important, the room has to be darkened. Okay, you cannot do indirect ophthalmoscopy in a fully nicely illuminated room with sunlight. The patient's pupil is fully dilated and the examiner is partially dark adapted. The fundus chart is clipped on a rigid board that rests on the patient's chest. It is oriented upside down, where 12 o'clock is towards the patient's feet and 6 o'clock has to be on the chin. So this is no exaggeration, but when we were doing our fellowship at Shankar Nitralaya, we had to have color pencils in our pockets, we had to have the 20D lab, in our lab pocket, and we had to have the fundus chart on the patient's chest, literally, and then start documenting what we were doing. So this is what I have already explained to you. Now what instruction do you give to the patient? Do you just start the procedure or you explain something? Firstly, important, ask the patient to keep his fellow eye open. Because if the fellow eye is closed, what happens? The Bell's phenomenon comes into place and the eyelid moves upwards, eyeball moves upwards, okay? If not possible, then ask the patient to look in different cardinal directions of gaze or use their thumbs for fixation. Now, how do we hold the lens? I have got the lens also with me. This is the lens, as Dr. Vishal was mentioning. The condensing lens is held between the thumb and the index finger like this. And these three free fingers are placed on the patient's face to stabilize the lens and retract the lids. So I'll come to this over here. I'll just come to this point a little later. Important to remember that the light beam should be central, illuminating the pupil completely. Slowly raise the lens while the pupil and the red reflex fills the lens view. Now this point is very important. The image system, that is the pupillary space, and the patient and the fundus of the patient's eye, your condensing lens and the indirect have to be in the same line. I have explained to you with a picture that I have of this. If the view goes black or appears inverted, you have moved too far away from the eye. So this is what I was explaining. So the first is the correct focal length, the middle one is too high, and the third one is too low. So important to remember, I told you that these two fingers will hold the lens, and these three fingers, they will act as pulley. They will never leave the chin. Okay? If you are holding the lens and these three fingers have moved away from the patient's chin, you will not get the image. So it has to be like this. Can you see? It has to be like this. These three fingers have to be on the chin, and then you have to move the lens up and down like this. Now, once you examine the posterior pole, you have to examine the fundus periphery. How do we do that? The examiner is standing at the opposite end of the meridian to be examined. So if you are examining the 6 o'clock position, the examiner is standing at 12 o'clock position and the patient is gazing downwards. Now the important things to understand over here, this is a very common problem which I used to face as a postgraduate. I didn't know where to stand, what I am seeing. So basically what you are seeing, in whatever quadrant you are seeing is actually in that same quadrant. You are not seeing something inferiorly and it is actually superiorly. Okay? So if you are seeing something which is in the 6 o'clock position and it is actually in the 6 o'clock position, but you have to make it easier, you ask the patient to look exactly where you want to see. So for example, if the patient, if the lesion is at 6 o'clock, you ask the patient to look at 6 o'clock, but where do you stand? You stand 180 degrees diametrically opposite. This is the important thing that you have to understand. A nasal, a temporal HST in my right eye, the patient, the doctor will be standing opposite over here, and the patient will be looking to the right, temporally. Okay, in exactly that same quadrant where the lesion is. Okay, do you understand? So the patient will be looking in exactly the same area, but the doctor will be standing 180 degree opposite. So this is examination of the posterior pole, including the disc and the macula, as you can see, and these three fingers are on the patient's face over here. The thumb and the index finger, if it is the dominant hand, the thumb will be retracting the upper lid and the other fingers will be retracting the lower lid. Okay? Now, see this, examination of the inferior retinal periphery. The patient is looking down and I am standing almost 180 degree opposite, and you have to tilt your lens a little bit. You have to tilt it a little bit. Okay? So you have to, it should be actually in a tangential line. Then only these three things will be in the same line. The lens, the illumination and the pupil of the patient's eye. Now see, what is this? This is superior retinal periphery. And I am standing 180 degree opposite and I have to tilt my body like a Bharatnatyam dancer. And the table of the patient, there should be some space for you to move around, all around. It should not be fixed on the wall. This is also an important point. You should be able to actually move around the patient's face to the other side. Now, technique of scleral indentation, what is it? It allows clear view of the structures in the retinal periphery, that is the ora serrata, posterior border of the ciliary processes. It permits kinetic evaluation, allowing a stereoscopic view. Now, technique of scleral indentation, just 2 slides on this. Postgraduates ask me, ma'am, I think it's a very painful procedure. No, if done properly, it is absolutely painless. Okay? How do you do it? The thimble is placed in the index finger. The blunt tip of the depressor is placed on the skin of the eyelid over the area of sclera to be indented. Now examination of if you are examining the upper fundus periphery, close the eyelid. The depressor tip is applied to the upper lid at the upper edge of the tarsus, and when the patient opens the lid and looks up, the tip of the depressor slides easily under the orbital margin. And always remember, the depressor should be used tangential to the globe. So I'm sure you've not understood much of what was there in that busy slide. I'm explaining to you with this diagram over here, with this photograph. Now here I want to examine the inferior, I want to indent the inferior retina and see the up till the aura, okay? So where do I ask the patient to look? 180-degree opposite. I'm asking the patient to look superiorly. And then the indenter is placed at the inferior edge of the tarsus, okay? Now, slowly ask the patient to look down. As the patient looks down, the indenter will slide like smooth, like cream below the tarsus, and you can easily see the structures. Okay? So ask the patient to look opposite. Put the edge of the depressor, and then when the patient looks down, automatically the depressor will go back. So in a nutshell, indirect ophthalmoscopy provides a stereoscopic view with a considerable depth of focus. A 20 diopter lens provides 37 to 40 degree field of view with 3x magnification, so it is commonly used. A condensing lens, this is a very important point. The higher the power of the lens, the lesser is the magnification and bigger is the field of view. So when we are doing ROP, we are examining with 80 diopter lenses because we want a higher degree field of view. Okay? And this is a slide which all postgraduates must be having in their Kansky and other books. So this is, differences between direct and indirect. So this all of you must know. So properly done indirect saves the patient's eye, saves your practice, and you can sleep well. So I'll just, in one or two slides, I'll go on to the difficulties which we encounter. Excuse me.
Hello.
Till then, if you have any problem, any points, co-instructors are sitting here, you can ask any points up till this procedure.
Anyone having any difficulties in doing IO, because that is very basic. Any queries, anything? Yeah.
Good afternoon, sir. When I'm looking at the field, if I'm looking at the inferior quadrant, I am unable to combine it with the posterior pole that I have seen. I am unable to, I'm a beginner, I'm in my first year residency, and either I'm missing the area between the posterior pole and inferior quadrant, or I'm missing the area after that inferior quadrant near the aura. And I feel like I'm looking at the patches, but I'm unable to form a complete wide field image in my mind, sir. Any tips for this?
Yeah, this is true. For that, you have to start learning how to draw, and that you should do at the time of examining only. What ma'am has shown in the initial pictures only, that when you examine the patient, you just place the fundus diagram on the chest of the patient or just beside the patient, and just draw in the, means the quadrant which you are seeing, just draw in that quadrant. The things which is farther to you, it's near, means you draw accordingly. And then you see, means after sometimes you will get like, after like if 1 or 2 months of practice, you can comfortably see all the lesions and you can draw after the whole complete examination. But that is a practice.
See, the thing is, first, either you see the posterior pole, and then you ask the patient to look up, down, right, left, supratemporally, supranasally. So what you're saying is right. You are going to miss the mid part. So the amount the patient, and that is why the thumb is important. The patient should always be asked to look at the thumb. How much rotation of the eye you want depends upon where the thumb is going to be. So the thumb is in center, you're going to see the posterior pole. The thumb is midway here, you're going to see in between the posterior pole and the periphery. And the thumb is here, you're going to see the periphery. So left eye, left hand, right hand. So where you position the thumb of the patient determines where you're going to see, which part of the retina you're going to see. Okay? So that is the difficulty that I think that you're having. So the positioning of the thumb is important. And as he said, Dr. Vishal said, when you start drawing, what you see, you draw. We have been spoiled by the wide field pictures that we want to see everything in one go. No, we can't see. Physically, it's not possible for us to see everything in one go. The drawing basically is going to mimic a fundus photograph, a wide field fundus photograph. Okay, so that is the difficulty that you are having. The position of the thumb is important, how much, where the patient is looking, which quadrant you ask the patient to look at. So posterior pole, midway, in extreme periphery, right or left. Okay.
And one more tip which I wanted to give, you know where the vortex veins are. So if you draw a circle around the vortex veins, that is the equator. And 8 to 9 mm beyond the equator is the aura. You can see it as a pigmented line. So that also you have an anatomical landmarks.
Apart from this, the next presentation, Dr. Salab sir will be explaining the diagrams and how you have to draw it. This is the fundus, whenever you're examining the patient, just place beside like this, upside down. And suppose if you are seeing this, suppose if the 7, you're asking the patient to look this side. So this is 7 o'clock. And when you are seeing the patient, you just have to remember what you are seeing near, you have to, since you are drawing it opposite, so it will be far off. Means what you are seeing, you just draw it. And when you just turn it upside, it will like things near to you is actually far off. And since you are drawing in a reverse order, you will see ultimately when you will properly place this diagram, it will be as what is there. So with the practice, you will get the orientation. But what is important, it requires practice. In your PG days, you should select few patients with a clear media. Just after your OPD, you regularly examine 4 to 5 patients. Initially, it will take time, but with the time you learn this, and it's very simple. And it gives confidence, especially you can, in a one go, you can see the patient. Thank you.
So now that we've spent 30 minutes, I am sure everyone knows that, oh wow, what an easy procedure this is. But no, actually there are a lot of difficulties in doing indirect. I'm not dissuading you, but practice makes perfect, okay? So these are the 4 points: poor doctor, poor patient, poor instrumentation, and some clinical situations. Now when I say poor doctor, I don't mean a doctor who is financially poor. I mean not a well-trained or a conversant doctor with this procedure. Lack of patients, too many patients, a government setup, lot of waiting, lot of patients queuing up, lack of motivation, and lack of time. A poor patient. Now this is a very nice picture of a baby lying nicely, comfortably, and the doctor is in a cool way examining the patient. But this is not how things are. The patient is struggling with hands and legs. The doctor is also in jitters. So an uncooperative patient, children, very elderly people cannot understand, cannot hear, apprehensive, mentally challenged, and a communication gap, lack of language. Poor instrumentation, we always forget that the lenses can be scratched, they can be misaligned, there can be dust on it many times, poor illumination, okay? And then clinical situations like orbital and lid disorders, conjunctival conditions, poor pupillary dilatation, media opacities, post-trauma, post-cataract surgery. So very prominent orbital bones, small palpebral fissures, very difficult to do this procedure in the beginning. Conjunctival conditions like chemosis, symblepharon, elderly diabetics, very small pupils, pilocarponized eyes. When there are synechia, uveitic eyes, many times it is not possible to do this. Media opacities, as you can see over here. A post-cataract surgery, when you have PCO, you have the IOL edge effect, especially when we are doing lasers when the indirect ophthalmoscopy. It is very difficult when you have a pseudophakic patient. The advantages of indirect and direct I have already explained to you. Do not depress in these situations. Post-PK and RK surgeries, if there is a presence of bleb, presence of rubeosis or hyphema, if there is a proliferative retinopathy and CNVM, a suspected glow perforation, and early post-operative period.